I would like to start by saying thank you to the event organizers for providing us with the opportunity to present our research on the outcomes in Hispanics with COVID-19 as compared to Caucasian patients in suburban New York. As the COVID-19 pandemic continues all over the globe, this is an excellent occasion to share acquired knowledge to assist us in combating this disease. I would like to thank my co-authors, the Department of Emergency Medicine, the entire faculty and staff of Stony Brook Medicine and Stony Brook University Hospital. Additionally, thank you to all healthcare and public health workers in the United States and around the world who are fighting against COVID-19. I have no conflicts of interest to declare, and no funding was received for this study. Here is the outline for today's presentation. Our research article was published in the Journal of Academic Emergency Medicine in October 2020, and full details about the research can be found there. It is impossible to ignore the difficult truth that there has existed and continues to exist a long and troubled history of marked disparities in healthcare delivery and outcomes in the United States of America along ethnic and racial lines. Prior epidemics and pandemics have seen similar disparities along ethnic and racial lines, from the Spanish influenza pandemic in the early 20th century to the H1N1 epidemic in the early 2000s. Early reports during the COVID-19 pandemic appeared to be no different, with multiple articles and studies suggesting increased incidence and worse outcomes among African Americans and Hispanics, as well as our own indigenous Native American populations. This was quickly picked up by the press and has continued to be highlighted throughout the duration of this pandemic. We hypothesized that our hospital would see similar trends of increased morbidity and mortality among Hispanic patients from COVID-19. Stony Brook University Hospital is located in Suffolk County, New York, which is approximately 60 miles or 100 kilometers east of Manhattan. It is a mix of suburban, exurban, and rural areas. Suffolk County differs in geography and population spread than many of the urban areas described in early reports, which highlighted disparities amongst COVID-19 patients. It has the third highest median annual household income out of 62 counties in the state of New York. The income gap between the county's upper and lower socioeconomic classes is smaller. Suffolk County is 67.2% non-Hispanic white versus 56% in the state of New York. Our Hispanic population is 19.8%, which is a similar proportion to the state. Blacks or African Americans make up 8.8%, which compared to the New York City area at 24.3%, where many of the early reports on outcome disparities emanated, is significantly lower. During the first wave of the pandemic, we noted an increase of Hispanic patients being seen at our center as compared to normal volumes. Given our population is primarily Caucasian and Hispanic, we limited our study to those population groups with COVID-19. We hypothesized that when compared to Caucasian patients, outcomes among Hispanics would be worse after adjusting for confounding variables and similar to reported increased morbidity and mortality among Black patients. The objectives for today's presentation are as follows. Objective 1. Is Hispanic ethnicity associated with higher mortality from COVID-19 in Long Island, New York? Objective 2. Is Hispanic ethnicity associated with higher intensive care unit admission or the need for invasive mechanical ventilation, which we consider as being placed on a ventilator via endotracheal intubation from COVID-19 in Long Island, New York? And Objective 3. Which risk factors are associated with increased mortality, ICU admission, or invasive mechanical ventilation from COVID-19 in Long Island, New York? We performed a structured, retrospective electronic medical review from the Cerner Power Chart application on patients who presented to the emergency department with confirmed COVID-19 based on a positive SARS-CoV-2 reverse transcription polymerase chain reaction, or RT-PCR, test from nasopharyngeal swabs. We also followed the recommended methodology of Kaji et al. For retrospective chart reviews. Due to the retrospective nature of this study, we received Institutional Review Board approval with waiver of informed consent. Our emergency department sees approximately 130,000 adult and pediatric visits per year. Eligible patients between March 7, 2020 to May 23, 2020 were included when they returned RT-PCR positive tests and further narrowed down to patients identified as Caucasian race and/or having ethnicity that was explicitly specified as Hispanic or non-Hispanic. We performed a computerized search and retrospective chart review of our electronic medical records to identify patients meeting all inclusion criteria. For eligible patients, we extracted patient demographics, including race, sex, comorbidities, such as the presence of diabetes, hypertension, chronic obstructive pulmonary disease, asthma, cancer, congestive heart failure, coronary artery disease, immunosuppressed status, chronic kidney disease, or body mass index greater than 30. We also examined COVID-19 exposure history, prior COVID-19 status, vital signs, symptoms on arrival, specific laboratory results, insurance status, disposition, and the need for invasive mechanical ventilation. Manual data abstraction by research staff included patient demographics, symptoms at presentation, prior medical history, previous lab results, radiology reports, the need for oxygen or ventilatory support, and disposition. All other variables were collected via computerized abstraction. Staff were trained to ensure that all data were collected via the same collection methods, and at the end of the study, a random sample of 200 patients, or 10% of the study cohort, was used to validate inter-observer agreement. Inter-observer agreement, or the kappa statistic for invasive mechanical ventilation, death, and COVID-19 positive test results, was excellent, a kappa of 1.0. Agreement for ethnicity was 0.94. For race, agreement was 0.99. And for ICU admission, agreement was 0.96. The primary outcomes for the study were the need for intensive care unit level of care and mortality. Secondary outcomes included the need for hospital admission, intensive care unit length of stay, need for non-invasive and invasive ventilation. We only used initial findings at emergency department presentation. Comparison between groups were performed using logistic regression. Multivariable analysis of primary and secondary outcomes was performed using potential predictor variables chosen based on biologic plausibility and previous reports in the literature. Level of significance was defined as having a p-value of 0.05 or less. During the preceding years of 2018 and 2019, Hispanics accounted for 21% of our emergency department volume, similar to the county population. However, during the study period, they represented 41% of patients presenting to the emergency department. Caucasians only represented 46.4% of patients during this time period. Thus, Hispanics represented a disproportionate amount of the volume of patients presenting to our emergency department relative to their overall county population and to our traditional emergency department volume. During the study period, 2,795 patients were diagnosed with COVID-19 by RT-PCR test. The analysis included 2,336 patients. Of those, 1,079, or 46%, identified as non-Hispanic Caucasians, and 960, or 41%, as Hispanic. We excluded 459 patients in whom racial and/or ethnic criteria were not determined. An additional 297 patients who identified as African American, Native American or Alaskan, Asian, Hawaiian or Pacific Islander, or multiracial patients were also not included because of their relatively smaller representation in our cohort. Age distribution differed substantially between Hispanics and non-Hispanic Caucasians. Caucasians were more likely to be older, with a mean age of 59 versus 45 years for Hispanics. Specifically, 39% of non-Hispanic patients were 70 years and older, while only 10% of the Hispanic patients belonged to that age group. Consistent with the skewed age distribution, a higher percentage of Caucasian patients had Medicare insurance, 18 versus 5%, or resided in a nursing home, 20 versus 2%, compared with Hispanic patients. Hispanic patients in this cohort were less likely to have commercial insurance and instead were more likely to be covered by Medicaid, 37% versus 18%, or registered as self-payers, 22% versus 3%, when compared with Caucasian patients. Notably, 66% of Hispanic patients reported no comorbidities versus 40% among Caucasians, while more Caucasian patients had one or more comorbidities, 34% versus 16%. Caucasians were more likely to suffer from hypertension, chronic obstructive pulmonary disease, asthma, cancer, and chronic kidney disease. Obesity was only assessed for admitted patients and did not differ between the cohorts. Both groups reported symptoms for similar lengths of time prior to presentation. Of all the patients seen during the study period, 1,043 were discharged from the emergency department, and 6 patients died in the emergency department. Hispanic patients were more likely to be discharged than Caucasian patients, 63 versus 41%. A total of 996 patients were admitted to the hospital. Caucasians were more likely to be admitted to a regular medicine floor as compared to Hispanic patients, and were more likely to be admitted directly to an intensive care unit when compared to Hispanics. It is noteworthy that more Hispanic patients required intubation and mechanical ventilation, 21% of admitted, compared to Caucasian patients, 15% of admitted. More importantly, despite lower intubation rates, mortality was higher for admitted Caucasian patients, 10% versus 3%. It should be noted that as an arbitrary endpoint was chosen for data collection to begin our analysis, disposition was still pending on 39 Hispanic and 45 Caucasian patients at the time of preparation of the data. Sadly, the ongoing nature of the pandemic precludes a neat endpoint when outcomes for all patients would be available to final disposition. Variables included into our models were male sex, age, ethnicity, fever and presentation of 38 Celsius or greater, tachycardia, heart rate greater than 100 beats per minute, hypoxemia, a pulse oxygen saturation less than 94%, tachypnea, a respiratory rate greater than 24 breaths per minute, and known exposure to COVID-19 infected individuals, as well as insurance status. These were examined with respect to hospital admission, the need for invasive mechanical ventilation, ICU requirement, and mortality. As we review the results, let us keep in mind the objectives we set out to answer. Objective 1. Is Hispanic ethnicity associated with higher mortality from COVID-19 in Long Island, New York? Our multivariable analysis showed that Hispanic ethnicity did not confer a risk of increased mortality from COVID-19 in our population on Suffolk County, with an odds ratio of 0.82, with a 95% confidence interval ranging from 0.46 to 1.47. Objective 2. Is Hispanic ethnicity associated with higher intensive care unit admission or the need for invasive mechanical ventilation from COVID-19 in Long Island, New York? Again, our data showed no link between Hispanic ethnicity as compared to Caucasians of having an increased risk of intensive care admission and the need for invasive mechanical ventilation. The odds ratio for ICU admission was 1.04 with a 95% confidence interval of 0.70 to 1.53, conferring no statistical significance. Similarly, for invasive mechanical ventilation, the odds ratio was 1.43 with a 95% confidence interval of 0.93 to 2.19, also without statistical significance. Objective 3. Which risk factors are associated with increased mortality, ICU admission, or invasive mechanical ventilation from COVID-19 in Long Island, New York? Variables that were associated with increased mortality were male sex, age, tachypnea, hypoxemia, and comorbidities. Variables associated with intensive care unit admission included male sex, tachypnea, and hypoxemia. Variables associated with invasive mechanical ventilation included male sex and hypoxemia. Ethnicity and insurance status were not associated with ICU admission, invasive mechanical ventilation, and mortality after adjusting for confounding variables. To determine whether the predictive factors for all outcomes were similar among Hispanic and non-Hispanic Caucasian patients, separate multivariable analyses were performed for each subgroup. There were no obvious differences in the variables associated with admission, ICU admission, invasive mechanical ventilation, and death between the two groups of patients. Healthcare disparities along ethnic and racial lines is not a new subject in the medical literature. It is an unfortunate reality that epidemics and pandemics only serve to highlight and to exacerbate these disparities. Quinn et al. Reported significant race and ethnicity-related disparities as a potential risk for H1N1, as well as worse morbidity and mortality in those populations around Boston. Similarly, media reports described increased COVID-19 infection rates as well as related morbidity and mortality in Black and Hispanic patients. However, our experience was different because we do not report worse outcomes when compared with Caucasian patients. We noted an increase in the number of visits to the emergency department from Hispanic patients, both when compared to prior years and in proportion to their representation in our catchment area. More Hispanic patients were seen and evaluated in our forward triage emergency department tent, 52% of Hispanics versus 29% of non-Hispanics, which was adjacent to a New York State testing facility, which may have attracted more people from outside of our hospital catchment area. Or it is possible that less severe cases, which included a higher percentage of Hispanics, were diverted to the tent. During the study period, the New York State testing facility was one of the few places COVID-19 testing was readily available and may have extended the distances well or mildly symptomatic patients were willing to travel. Hispanic patients tended to present from a handful of zip codes in our catchment areas. They tended to be younger and tended to present from home and not from nursing homes. They exhibited less pre-existing medical comorbidities, which may have been due to their younger age, but it could also be explained by differing access to regular medical care. While more likely to be intubated, they were less likely to die if intubated. These factors all likely contributed to lower mortality when compared to Caucasian patients. Our multivariable analyses showed that being Hispanic was not associated with mortality even after adjusted for age, comorbidities, insurance, and domicile. Our results appear to differ from those reported in other studies that have highlighted worse outcomes in minorities who are diagnosed with COVID-19. While rates of COVID-19 infection were higher among our population of Hispanic patients, we did not see worse outcomes in our patients in suburban New York. This is because outcomes in COVID-19 infections are not tied directly to race or ethnicity, but rather differences in COVID-19 morbidity and mortality are likely the result of a complex interplay of socioeconomic, cultural, social factors, and healthcare accessibility factors among different groups of patients. A major difference between our study and previous studies is that we examined the outcomes in a predominantly suburban Hispanic population. When compared to the airport or East Elmhurst area of Queens, identified by the New York City Department of Health as one of the areas with higher rates of COVID-19 infection, the Brentwood area of Long Island, which represented 25% of our patients and has comparable percentages of Hispanic residents, 67 and 64% respectively, socioeconomic parameters differ significantly. Data from Brentwood indicate a higher median household income, fewer persons living below the poverty line, increased commuting by car versus public transport, fewer average persons per household, and a majority living in a single unit residence. All these factors emphasize the Hispanic population in Suffolk County is markedly different from the inner city Hispanic population in some key ways. Rather than intrinsic genetic differences, socioeconomic characteristics, access to healthcare, and housing characteristics may be more likely to affect outcome. Other potential reasons why we did not see worse outcomes in Hispanic patients in our hospital include our high availability of ambulatory testing. This may have skewed results towards healthier or wealthier Hispanic populations who were able to travel even while being under or uninsured or having limited access to routine healthcare. Our study has several limitations. Our data represent a single institution's experience, which may not be generalizable to other settings. Criteria for and availability of testing of ambulatory patients was done according to CDC and Department of Health standards and guidelines at the time, which continued to change through the pandemic. The reliability of the tests appears to be dependent on many factors and may lead to a significant number of false negative results. The data we collected were retrospective and subject to all the typical limitations of study design, including selection bias, unmeasured confounders, errors in data entry, and residual confounding. We did not compare income directly, rather using surrogate markers. We also did not take into account patients' housing density or other potential environmental factors like the use of private or public transportation, ability to work from home, work exposures for essential workers. Finally, this study did not examine potential bias against Hispanic patients by healthcare workers as a potential factor in differences in discharge rates versus admission. While our results differ from the numerous reports of increased morbidity and mortality in minority patients, it highlights that socioeconomic, cultural, and environmental factors may be much more significant in explaining the deleterious effects seen in minorities living in more densely populated areas in the epicenters of COVID-19. Our data showed that Hispanic ethnicity conferred no increased risk of mortality, no increased risk for the need for ICU admission, or the need for invasive mechanical ventilation. This work represents an important step in identifying at-risk populations. Future research should examine the relationship between race and ethnicity with respect to the socioeconomic, cultural, healthcare accessibility, and other factors that may have protected our population. Only once we understand the complex interplay of these factors will we be able to bring preventative and treatment efforts to bear in a way that can reduce the disproportionate morbidity and mortality within these racial and ethnic groups in other environments. Select references are listed below. For a complete list of references, please see the publication in the Journal of Academic Emergency Medicine. I thank you for your time and for your attention. Should you have any questions, I can be reached at the following email: